This is a recording of a webinar on June 4th. The webinar is Home Care Through a Disability Lens.
Good afternoon. This is Elly Kugler with the National Domestic Workers Alliance. I'm the Federal Policy Director for the National Domestic Workers Alliance. I apologize for the delay in getting the webinar started, but I think we're just about ready to go. If everyone can just be patient and give us 1 or 2 more minutes. We're just finishing up our webinar setup, so thank you to everyone for bearing with us, and we will start in just a moment. Alison or Mollie, please let me know if you've been able to join the line. All right, thank you to everyone for your patience. Please hold for a moment longer. Again, to everyone who's joined us, thank you so much for your patience. We're just experiencing some technical difficulties with the webinar. We should be starting momentarily. We appreciate your patience. Thank you. and thank you for your patience. This is Elly with the National Domestic Workers Alliance. We are still experiencing technical difficulties. We apologize sincerely. In your confirmation that was sent out, the slides that we're going to be covering are in there if you want to take a look at them. We're just having some difficulties getting the presenters, who you are all online to hear, actually able to present to you. So we're working on that right now. I thank you for your patience. If anyone needs to drop off, we will be making a recording of this presentation, so we can also share that with you at a later date. Thank you. Hi, this is Alison Barkoff. Can you hear me? We can hear you, Alison. Thank you so much for overcoming the many technical barriers that we've been running into. We're so happy to hear your voice. If we want to go ahead and get, let's go ahead and get started. I think that everyone is aware of Alison Barkoff's role at the Basel Center for Mental Health Law, and that's a large part of why you're on this training. We're very fortunate and lucky to have Alison on this call. She's going to be running us through a very broad overview of the structure of home care systems with a particular focus on disability rights and the rules that home care systems that are state-funded need to comply with to ensure that they're in accordance with the civil rights laws that have been won by organized communities of people with disabilities engaging in social movement over multiple decades. So we're very fortunate to have Alison on. We have Mollie as well, an additional presenter who I think we're still working at getting on. But Alison, if you want to get us started, I don't think people can see the slides on the screen yet, but they were sent to you in the email that was the confirmation email about this presentation. So folks can open up that email of slides and follow along as Alison talks through the slides. Thank you so much, Alison.
Thanks. So thank you, everybody, for having me today. And again, sorry about all of the technical difficulty. The goal of today is really just to present a very broad overview. I know we have a wide audience, a lot of people who come from the worker advocacy world who know a lot about worker rights and some of the statutes protecting worker rights, and may know less about the Medicaid system and the intersections with disability rights. And for those of you who I know I afforded this to, we do actually have some Medicaid experts on the phone too. I just want to give a fair warning. This is really just a very, very high level overview so people just have a sense of some of the different ways that home care programs may be funded in disability systems in your state. So the couple topics we're going to cover today are a very, very high level overview of Medicaid and disability law. We're going to talk a little bit about the models of home care programs, particularly focusing on consumer-directed models, and we're going to touch on some of the implications around the home care rules. So the first thing just to put a frame around is why the home care programs are so important to the disability community. I know all of you have been engaged around the recent home care rules, certainly have been following the engagement of the disability community, and we care a lot about home care because these programs are critical to helping people with disabilities live in their own homes and fully participate in community life. And these programs have been the result of a long, long fight to expand community-based services under Medicaid as an alternative to nursing home care. And finally, when we talk about consumer direction, and I'm going to get into each of these themes a little more, again, that reflects a very big fight from the disability community to push for models that give consumers more control over their own lives and their own care. So I just want to put a little bit of a frame about, before I jump into the weeds of Medicaid, about kind of where we've been historically in the disability world. So historically, as many of you probably know and can appreciate, institutionalization of people with disabilities has historically been the norm, and from the late 19th century until at least the 1970s, and still continuing legacies in our system, there were institutions, and the majority of people with disabilities were in them focused on custodial care, everything from what's called institutions, intermediate care facilities for people with developmental disabilities, to psychiatric hospitals for people with mental illness, to nursing homes. And in these facilities, there was very little treatment or teaching new skills or working towards independence or recovery. It really was around custodial care. And at that time, families were told institutionalization was kind of the only option for their children. Kids with disabilities had no right to a public education at that time. So that's really kind of the framework where we start from. And people with disabilities really were not empowered to make decisions in their own lives in any kind of way. Okay, I see my slides are showing up. So Mollie, please forward to the disability rights movement, please. So starting in the late 1960s, really building off the momentum in the broader civil rights movement, people with disabilities really pushed for more control over their own lives and broader access to the community. In many ways, this was driven initially by the independent living movement and groups like ADAPT. Families began fighting for the supports to raise children with disabilities in their own homes, and with exposés about the abuse and neglect that was happening in institutions, advocates fought for community services and for getting people out of institutions. And out of the disability rights movement, and Mollie, if you could forward this on to about the fourth or fifth slide, and out of the disability rights movement really came this vision for people with disabilities, and I think that you'll hear these themes infused throughout both the pushes in the Medicaid system that I'm going to touch on, as well as around the civil rights laws. Another slide or two, Mollie, please. So this vision is really around full inclusion of people with disabilities in all aspects of society, from school to community living to work. Self-determination, so people having control, making their own decisions, dignity of risk, choice, driven by people's own preferences and goals. One more slide, Mollie, please. And high expectations for people with disabilities. So that really is kind of the platform of the disability rights movement that started 30, 40 years ago, and it still really drives our movement today. Next slide, please. So over the last 25 years, because of the disability rights movement, there have been really significant changes in the opportunities for people with disabilities. The first has been a development of community-based services as an alternative to institutional care, and that's primarily funded through Medicaid, and I'm going to spend some time walking through kind of an overview of Medicaid. And then the second piece that has come out of the disability rights movement is the creation of civil rights laws that give basic rights and protections to people with disabilities and protect against discrimination. And these civil rights laws ultimately culminated in the Americans with Disabilities Act. So next slide, Mollie. So I'm now going to give a very high-level overview of Medicaid, and for those of you who are Medicaid mavens on the phone, I've really tried to boil this down to a nutshell. So this is very general, but hopefully gives people a flavor of the complexities and issues as we think about making significant changes to community-based services in Medicaid systems. Next slide, please. So Medicaid is the primary funding source for long-term services and supports for people with disabilities and seniors, and that includes home care services. So, people often have asked, what about Medicare? Well, Medicare certainly is something that a lot of seniors have access to, all seniors. And some people with disabilities are dually eligible for Medicaid and Medicare, but they typically do not fund long-term services and supports in the community, typically only intermittent or short-term home health care in this home care.
Call recording is on.
And some people may have private long-term care insurance, but that's not very common for people with disabilities. And frankly, people with disabilities typically, quote, spend down to become financially eligible for the wider array of long-term services and supports covered by Medicaid. So next slide. So just the very high-level basics of Medicaid. It was established in 1965 as a medical insurance program primarily focused on individuals in poverty. And Medicaid is an optional program for states, although at this point all states participate. Medicaid is a joint state federally funded program, so states have to put up matching dollars to draw down federal dollars for Medicaid services. And the typical rate is about a 50-50. Maybe the average now is 56% that the feds pay, 44% that states pay. But that varies by state depending on kind of the poverty levels in the state, as well as I'm going to touch on there's some services that get a higher match. In terms of eligibility, there are mandatory categories of eligibility and optional categories, and this is done at a state level. Once a state decides to participate in Medicaid, they can set the eligibility category. So just to give you a flavor, all states have to cover very low-income families, pregnant women, and people with disabilities and older people who qualify for Supplemental Security Insurance, SSI, which has very, very strict financial limits. Optional categories, so states can set higher income thresholds for pregnant women, infants and children, foster children, and so really when we look at Medicaid populations, there is a wide variety by states. Next slide.
And again, Alison, I'm just going to interrupt for 1 second, and just there's some attendees who are letting us know that they're not able to see the slides through Join Me. So just a reminder, the slides were also emailed to you. I'm going to email them to everyone one more time. And we're on the slide that's entitled Medicaid Eligibility Continued. So if you're having trouble seeing, feel free to pull up those slides from your email and follow along with the same slides. I apologize for the interruption.
Okay, thanks. So again, we could do a whole webinar, and many of you probably have been to them, around the Affordable Care Act and what the expansion populations are. Again, just to remind people, after the Supreme Court's decision, states do not have to expand. I think we're up at somewhere in the 30s to states that have chosen to expand. And what the Medicaid expansion population does is anyone who meets a particular poverty level can participate in Medicaid. This is one place where there is a different match, and so for expansion population, the federal government actually pays 100% for the first 3 years and then 90% thereafter. I just want to flag for people, and again, this is a place where it really varies by state. The expansion population has access to an alternative benefit plan, and that's kind of teed to a federal marketplace. That does not include all of the benefits that are typically in a state's Medicaid benefit package for a traditional Medicaid population. But for people with disabilities who are in the expansion population, they can opt into the state's traditional Medicaid program if the alternative benefit plan is not aligned with the traditional program. So again, just to emphasize, states have a lot more flexibility in setting the plan for the expansion population. Some set it the same as their traditional Medicaid program, so they don't have to administer two different programs. But for people with disabilities, they do have an option to jump in. And So let's see. Next slide, please. So I'm going to just give you a very high-level overview. Now I'm going to go back to kind of traditional Medicaid. And I want to talk about kind of the buckets of services that are there, and I'm going to highlight the ones where home care programs, personal care services, personal attendant services, they're known by a lot of different names, but I'm going to highlight the different ways that they might be covered in your state's program. So the first bucket of services that are covered under Medicaid, and they're mandatory, meaning that if a state chooses to participate in Medicaid, which every single state has, then they must provide these services. And the first set of services are institutional services. So these include nursing homes, hospitals, and intermediate care facilities for people who have intellectual and developmental disabilities. I want to just highlight that institutions for mental disease, IMDs, what people might think of as psychiatric hospitals, are not covered by Medicaid at all. They are disallowed and must be funded by all state dollars. And so that's going to make a difference when I talk about some of the community-based programs that require an institutional level of care. But nursing homes, hospitals, ICFs, they are institutional services and they are mandatory. So anyone who meets the eligibility for these services, it has those as an entitlement. Next slide, please. A second bucket of services are state plan services. And under state plan services, again, once a state chooses to participate in Medicaid, they must offer some state plan services that are called mandatory services. And then there are optional state plan services that states can offer. So mandatory state plan services are primarily traditional medically related services. So services like inpatient and outpatient hospital services, physician services, nursing services, prescription drugs. For those of us who kind of work on the community-based services side, and I'm going to talk about kind of the institutional bias in Medicaid in a minute, most of the state plan services that are really helpful for people with disabilities to live in the community are optional state plan services. And those include, so there is a state plan, optional state plan service called personal care services. That's one of the key ways that home care programs are funded. It also includes rehabilitative services, which cover a range of services to help people live in the community, case management services, clinic services, therapy services like occupational therapy and physical therapy. Next slide, please. So the way state plan services work is Medicaid sets out very broad definitions of what is coverable under each of the categories of state plan services. So they have a broad definition of what can be covered under personal care services, for example. But states have flexibility in setting the eligibility and the limits or caps for different state plan services. So a state might say we're going to offer personal care services. We're going to say that for people to be eligible for this service, they need to have the following kinds of functional limitations and their activities of daily living or instrumental activities of daily living. We're going to offer a max of 40 hours a week of personal care services. That's all allowed. States have flexibility. But once the state sets the eligibility for state plan services, anyone who meets eligibility is entitled to get those services, so they are not allowed to have wait lists. And I'm going to contrast that to some other services where you can have wait lists. State plan services do not require an institutional level of care. So states can set eligibility much lower than an institutional level of care. And in state plan services, there are requirements of statewide-ness, meaning that the services have to be offered across the whole state. You can't geographically limit it. And that the services are comparable across the state. Next slide. So Personal care services, and again, I just touched on that, is one of the important state plan services for home care programs. It goes by other names in different states, such as personal attendant or personal assistant services. And as I mentioned, it's generally defined as human assistance with activities of daily living. Those are called ADLs, and that includes things like eating, bathing, dressing, and instrumental activities of daily living, so IADLs. And those include activities like cooking, shopping, going out into the community, assistance with using transportation. And personal care services can be provided in a person's home or anywhere out in the community. So PCS is a service that someone could use to, go out in the community and go shopping, go out and do recreational activities, have a personal attendant with them at work. Next slide. So we've now talked about institutional services. We've talked about state plan services. Another bucket of services are called 1915C waivers. And I'm going to apologize in advance that, unfortunately, a lot of these names have numbers and letters in them, but hopefully those slides will help you keep them straight. So initially, there really wasn't any way to create a robust package of community services for people who had pretty intensive needs. So starting in 1981, this was a result of a family of a child named Katie Beckett who was in a hospital. When she was in a hospital, she could get institutional services and a robust package of services there. Her parents wanted to take her home, and if she was home, there was nothing for her. So they created something that was first started and called the Katie Beckett waiver, which then became 1915C waivers. And 1915C waivers allow states to cover a wide range of services, either at higher levels than what's available in state plans, as well as additional services that are not covered by state plan services. So things like respite, residential support, specialized therapies, habilitative services, and supported employment. And personal care services are often included in waivers, either higher levels and caps that are available, so a higher number of hours, or if the state doesn't offer personal care services in their state plans, they might offer it in a waiver. And historically, waivers have been, states have multiple waivers. They're targeted to different disability populations. It wasn't until recently that you could actually combine them. So a state might have a 1915C waiver for seniors. They might have a physical disability 1915C waiver. They might have an intellectual disability 1915C waiver. So a lot of states have a lot of waivers. Next slide, please. So a couple key features of waivers, and again, I'm going to contrast this. If you could go back one slide, please. So waivers, anyone who receives a waiver must meet an institutional level of care. So that means that, waivers really only are a helpful Medicaid authority for people with physical disabilities who may be, or seniors who may need a nursing home level of care, people with intellectual and developmental disabilities who need an intermediate care facility level of care, or people who are in a hospital. Remember, IMDs, psychiatric hospitals are not covered, so 1915C waivers in general are not very useful for people with psychiatric disabilities. And one thing I want to mention, this relates both to the institutional services and these waivers, is states have flexibility in setting their institutional level of care. Again, if you look across the country, let's just use nursing homes for an example. Some nursing homes require a lot of functional limitations in ADLs and IADLs. Some have a much lower level of care. States have discretion to set that, but what they can't do is have a higher level on the 1915C waiver side than they do on an institutional side. So if a state wants to have a pretty generous 1915C waiver, then they can they can do that by kind of having a lower institutional level of care across the board. And vice versa, if a state was trying to kind of limit community-based services, they cannot set higher ADLs and IADL limitations for a 1915C waiver than the institutional level of care. Another key feature is that waivers require cost neutrality, which means that the community-based package cannot be higher than the cost of institutional care. And states have discretion in whether to set the cost neutrality and look at that based on an individual cost cap. Most states do not do that. It's a really a very bad way to do that because, frankly, some people are lower, but some people are above. Most states use a global cost cap, but again, when we start talking about some of the problems that people are running into in home care programs, some of the individual cost caps can be a problem. Next slide, please. The other key feature here is that states, unlike state plan services that I talked about earlier, can limit the number of people who receive services. So they can have a certain number of slots and then they have wait lists. So right now in this country we have over 100,000 people who are on wait lists for waivers. And that means that every single person who's sitting on a wait list, when you hear about this, could immediately, today, they have an entitlement to be in an institution. They need an institutional level of care, yet that's not what they want. They're sitting and waiting on a wait list for community services. And just so people have a sense, states have a lot of discretion about that, how they administer these wait lists. Some do it on a kind of first-come, first-served basis. Most people, especially now, as they're kind of cognizant of some of their responsibilities under civil rights laws and really best practices, really look at what's the level of need of people and people who are in crisis situations who might otherwise, be forced into institutional settings. But again, lots of discretion to states around waivers. Next slide, please. So those are three big buckets of kind of traditional Medicaid programs. I want to talk a little bit about the Medicaid institutional bias, and then I want to talk about some of the more recent programs that are starting to chip away at that. So Medicaid has this institutional bias, and it really has led to people being needlessly institutionalized. And the two things that I really think of when I think about Medicaid's institutional bias is the first, that, as I mentioned, institutional services are an entitlement under Medicaid. But all the services that I have talked about that are kind of robust community services for the most part, and all the services I'm going to talk about in a moment, are optional services. So states don't have to offer those. And even the ones that do offer them, many of these have people on wait lists for these services. The second piece that has really created a problem is that Medicaid pays for room and board in institutions. They pay the full cost of someone in a nursing home, for example, or in a ICF, but they are prohibited from paying for room and board in the community. So many people end up being stuck in institutional settings, even if they could move to the community and have access to community-based services because of a lack of affordable housing. Next slide, please. So just to give people a sense of how far we've gone and how far we're coming, if you kind of look over the last 25 years or so, the top line is a graph of institutional spending to community spending. This is kind of a national average. We've gone from the vast majority of money being in institutional care just in the late 90s to a near 50-50 split. And next slide, please. I just want to let people know there's really a wide variety across the country. This is kind of state spending. If you look at kind of on the low end, we have New Jersey and Mississippi, who spend just a little more than a quarter of their spending on community-based long-term services and support, and on a high-end, states like Minnesota and Oregon. And if you break it up even further by disability population, population. We, in general, have a lot more spending on community-based services for people with intellectual and developmental disabilities, kind of the highest level of spending. Then kind of going down the list, seniors and people with physical disabilities have a little less good ratio of community to institutional spending, and then the worst is in for people with psychiatric disabilities. Next slide, please. So I want to touch on a couple of the new authorities that have begun to address the institutional bias, and I'm going to highlight which of these services cover personal care services or home care services. And really what I want people to understand and take away from this is that there are a lot of different ways in your state that home care programs might be covered, and they have a lot of different implications. So a recent authority is called the 1915 I-State Plan Home and Community-Based Services. It's a little bit of a hybrid between a 1915C waiver and traditional state plan services. It was created actually in 2005 by the Deficit Reduction Act, but it was significantly improved in 2010 with the Affordable Care Act. It's an optional home and community-based service state plan service that allows you to cover the entire range of services that could be covered under 1915C waivers. So that means you can set higher level of services. It means you can cover services that are not coverable under regular state plan. The thing that's different about 1915I than 1915C is states can set eligibility lower than an institutional level of care. You can target it based on functional limitations, and there are different ways that states can target this. Again, the concern with state plan services is that anyone who's eligible has an entitlement to that. So obviously once you open up that service, states have to be able to come up with their state match. There are ways that states can target. You can target it, for example, to a particular disability population, and a lot of states that have 1915I so far have done that. Next slide, please. So another new authority that came out of the Affordable Care Act is called 1915K Community First Choice Option. And again, this is another optional state plan service, which is focused on providing home and community-based attendant services. So again, personal care, personal assistant services, home care services, that's the same wording. It's really helped with ADLs and IADLs. And this was created by the Affordable Care Act to really be an alternative to nursing home services. But it really was intended to incentivize states to expand personal care and home care programs. And so instead of the regular match that a state has, they get a 6% enhanced federal match for community first choice services. And right now, at least according to CMS's website, there's only 4 states that have approved 1915Ks. That's California, Maryland, Oregon, and Montana, but many others I know have those in the work. Many states are working to transition personal care service or home care programs from state plan services or out of waivers into CFC because they get the enhanced match. And as we'll talk a little bit later about ways that states might either expand eligibility or expand the number of people who are getting personal care services or to pay for compliance with the new home care rules, assuming that they're upheld. A lot of people are looking at kind of this enhanced federal match as a potential. Next slide, please. So briefly, other programs.
Yes, Alison, just to jump in quickly, as folks are having questions come up, if you can please email them to Elly, ELLY, @domesticworkers.org. Again, email questions as they come up to ELLY@domesticworkers.org. That's the same email that you got the slides and the confirmations from. Send those questions to me, and after both Alison and Mollie present, then we'll go through those questions in order from sort of more general questions to most state-specific questions. So if you're having questions, that will be how you get them answered. We have a lot of space at the end of the training for that to happen. Thank you, Alison. Sorry to interrupt.
Okay, thanks. So I just want to touch real briefly on two new authorities that have been strengthened and expanded in ACA or created. One is called Money Follows the Person. It pays 100% transition costs and services for the first year of people transitioning from qualifying institutions, again, typically nursing homes or ICFs, to qualifying community settings. And again, personal care services are very much often a part of the package of services there. And then there's a program called the Balancing Incentive Program that provides a federal match to states to use to really work on rebalancing their ratio of institutional to community spending. And the enhanced match really depends on how out of balance that you are. Next slide, please. Mollie's going to spend some time talking about Medicaid consumer direction. I just wanted to kind of highlight the way this is really
All participants are now unmuted.
Okay. Elly, I think it's Elly. We could
Everyone can mute their phone.
Okay, if everyone can hear star 6 to mute the phone. Okay, everybody, please mute your phone.
Presentation mode. Your line is muted. All participants are now unmuted. The conference is now in presentation mode. Your line is muted.
Great, let's keep going.
Okay, so
all participants are now unmuted.
Lisa, if you could do it one more time, I think we'll go. Okay, so Medicaid consumer direction. Okay, so Medicaid.
The conference is now in presentation mode. Your line is muted. All participants are now unmuted.
No.
God. The conference is now in presentation mode. Your line is muted. All participants are now unmuted.
Okay, I'm going to keep going. Hopefully, Lisa, you'll get this. So Medicaid started, it was a casting, counseling, demonstration.
The conference is now in presentation mode. Your line is muted. All participants are now unmuted.
Oh my God.
Poor thing.
Okay, I'm just going to keep going. I don't know if you'll get there. So, Medicaid consumer direction started as a counseling demonstration.
The conference is now in presentation mode. Your line is muted. All participants are now unmuted. All participants are now muted. Press star 6 to unmute your line. All participants are now unmuted.
Okay. I'm going to try to keep going. I don't know if people can. So this was started. This was started as a consumer direction program. So the consumer direction program initially started as a demonstration. And in 2005, it was, I'm not sure if people can hear.
Alison, I hate to say it, but we can't really hear you.
Okay. Elly, do we want to do the calling number? Okay.
Yeah. Hey, sorry folks, we have no idea why it keeps going back and forth from the muted and unmuted. I have a conference line you can use if you want to. Share with everyone. If they can hear me, I could share it over verbally. Is that Mollie? Yes. Yeah, you know what we'll do? We're going to use a conference number. Just to finish up the presentation, we appreciate everybody being really patient. But this, Mollie, if you could say it one time and then we'll email it out as well. Sure. 6, 1, 7, 2, 2, 1, 4, 6, 5, 7, 10, 1, 2, 3, 7, 4. I just put it in the chat. Excellent. Thank you.
Okay.
Thanks everyone for your patience. Please let's stay on the webinar on your computers.
I guess they've changed to a different phone number and I don't have it. They said they were going to email it. I got the new phone number.
Authority for managed care in a number of states. There's also something called 1915B managed care waivers. Sometimes they're combined with 1915C services. So there are some 1915 BC states. And again, depending on the authority, that can be used to cover some additional services that come from cost savings or can be used to kind of restrict the number or types of providers. Okay, so that's a very high-level overview of Medicaid. I'm going to really, really quickly touch on disability rights laws and then turn it over to Mollie to talk about consumer direction. The first real significant disability rights law happened in the early 1970s called the Rehabilitation Act, and it prohibited discrimination against people with disabilities by recipients of federal funding. So pretty narrow. I mean, lots of people get federal funding, but it didn't cut across everything. And so, again, just to kind of get a sense of the disability rights movement and how it really drove this, there were some very famous sit-ins by disability activists, Nickel, ADAPT, people who are still very active in that movement to get federal agencies to issue regulations. While the Rehab Act had a lot of important impact on a lot of issues like transportation, physical accessibility, it did not impact integration and community services as much as people had hoped. I'm going to remind people, please put yourself on mute. Thanks. So next slide, this culminated in kind of the disability rights movement really pushing for kind of a bigger and broader civil rights law. And in 1990, the ADA was passed to provide a clear and comprehensive national mandate for the elimination of discrimination against people with disabilities. And it specifically found that segregation, isolation, exclusion, and institutionalization of people with disabilities, even in 1990, was a continuing, serious, and pervasive problem. And the goal of the ADA is to ensure equality of opportunity, full participation, independent living, and economic self-sufficiency. Next slide, please. There are a number of titles in the ADA. I'm going to focus today on the part most relevant to the public service system, and that's Title II of the ADA, which prohibits discrimination by public entities in all services, programs, and activities. And the Department of Justice is the agency that's charged with enforcing the ADA and issuing regulations. And after the ADA was passed, it issued an integration regulation, which requires that all public entities, services, programs, and activities be administered in the most integrated setting appropriate to people's needs, which is defined as a setting that allows people with disabilities to interact with people without disabilities to the fullest extent possible. Next slide, please. So in 1990, there was a real question, and keep going, Mollie, before the Supreme Court. In traditional civil rights law, basically, you have to show that people are being treated worse, a protected group, than people who are not within the protected group. But actually, the ADA is about leveling the playing field. And in some ways, people with disabilities need things like reasonable accommodation and are part of programs that people with disabilities aren't part of. So a case went up to the Supreme Court involving two women who were institutionalized in Georgia's mental hospitals, who the state's own treating professionals said they could be served in the community, they wanted to be served in the community, but the state said we just don't have services. Keep going, Mollie, on this slide. The Supreme Court held that it is discrimination when states do not provide. People could please mute. I don't know. Elly, please put your phone on mute. So the court found that states violate Title II of the ADA by unjustifiably segregating people with disabilities. And they said that segregation perpetuates assumptions that people with disabilities are unworthy of participating in community life, and it also limits their ability to participate in the everyday life activities that we all take for granted, like family, work, education, and social contacts. Next slide, please. And the Supreme Court said that public entities are required to provide community-based services whenever those services are appropriate. Affected people do not oppose community-based treatment. Keep going on that slide, Mollie. And community-based treatment can be reasonably accommodated when you look at all of the resources available in the disability system. So I just want to touch on a couple small pieces about the ADA and turn this over to Mollie. Mollie. So when is the ADA's integration mandate implicated? And keep going, Mollie. So people, even though the context of the decision came up in the context of the state operating state-run facilities and programs, it's not limited to that context. Keep going, Mollie. It applies anytime government programs result in unjustified segregation because either the government is operating the program or facilities, they finance the segregation of people with disabilities, and that could be in private placements, or they promote segregation through planning, service design, funding choices, or practices. Next slide. The integration mandate not only covers people who are currently in institutions or other segregated settings, keep going, Mollie, but they also extend to people at serious risk of institutionalization or segregation, and that's really what's going to be relevant in the home care context. So that includes people who might be subject to cuts in services that put them at serious risk. So, Mollie, if you could just skip ahead to service cut cases. People can look at my slides about how integrated and segregated settings are designed, but there's been a whole set of cases talking about what does it mean to be put at risk of institutionalization, how can states cut services, and how are they not allowed to? So in the recent economic downturn over the last 5 or 6 years, many states tried to cut optional Medicaid services to address budget shortfalls, and they particularly focused on personal care services and home care programs. And there was a number of legal challenges to these proposed cuts, claiming that when it was an across-the-board cut, so saying we're going to cut 20% off all people's personal care services, that it would place people at serious risk of institutionalization and violate the ADA and Olmstead. So litigation, for example, in Washington State, California, and Louisiana. Next slide, please. So the long and short of this litigation and weighing in by the Department of Justice and some very successful court cases is legal precedent that shows people do not need to show that they are at imminent risk of going into an institution. They don't need to show, I've applied to a nursing home. All they need to show is that there's a serious risk of institutionalization to have a claim. The second part is that across-the-board cuts, where you don't look or have a process of looking at the individualized needs of people and their capacity to bear the service cuts, can violate Olmstead. And flowing out of that is that states must have in place an individualized process for people who are claiming to be at serious risk of institutionalization to either seek an exception from the cut or to get alternative services put in place. Next slide, please. So in terms of the home care rule, I just want to, this is my last point, and then I'm going to turn it over to Mollie, to let people know that there are Olmstead implications when we're thinking about the new home care rule. And a lot of disability advocates have been concerned that if states comply with the new home care rule by putting in place restrictions like hard caps or restrictions on worker hours, that could translate to a reduction in services for consumers. So in response to those concerns, in December of 2014, the Department of Justice and HHS's Office of Civil Rights, both of whom have jurisdiction to enforce Title II of the ADA, issued a Dear Colleague letter addressing Olmstead implications around the home care rule. Next slide, please. And this letter says that the ADA and Olmstead generally prohibit across-the-board restrictions and caps on worker hours. So anything that would translate to cuts or limits on hard cuts and limits on consumer hours could violate Olmstead. The letter noted that states have obligations both when they directly operate home care programs and when they operate them through private entities, whether that's through the managed care program or through a consumer-directed program like an agency with choice. And it said that states must have in place an exceptions process to any kind of restrictive policies for people who are put at serious risk of institutionalization. So that could include consumers who can't find additional workers to meet the hours that have been allocated to them. They have extraordinary behavioral or medical needs that leads them to not be able to tolerate multiple workers or emergency situations. Next slide. So the last slide is just some potential resources about Medicaid, about Olmstead enforcement, and about the worker home care rule. And I will turn it over now to Mollie to talk about consumer direction and hopefully have less technical issues than me.
I'm going to talk so fast, everyone's going to wish we had static again. All right, here we go. We're about to get those slides. I'm going to talk a little bit about participant direction. I'll go ahead and, there we go. Great. I just want to give folks an overview of self-direction, because one of the things that I'm sure you're thinking about or hearing about in relation to the home care rule is how self-direction, consumer direction, or participant direction programs fit in. I'll call these programs self-direction or consumer direction for purposes of this webinar, but like lots of things in self-direction, the actual name of it goes by a few. So it's usually self-direction, consumer direction, or participant direction. There's a self-directed program, at least one, in every state in the country. In several states, in many states, there are multiple self-direction programs, usually using one of the authorities that Alison talked about earlier today. This slide also shows those states that have only employer authority, employer and budget authority, a veteran program, which is VDH-CBS. So you've got colors for that, but we don't need to worry too much about that right now. Let's get into what is a self-direction program. So go ahead and go to the next slide. So what is self-direction? The idea behind self-direction is pretty simple, although sometimes implementing it can be complex, especially because across self-direction there are so many different names for everything. But the idea behind self-direction is that the individual who's receiving the services, or someone close to the individual who's receiving the services, is in control of the services that are being delivered and who is delivering those services. So rather than a model of service delivery where an agency or a service provider or a hospital or a medical person is in control of what happens, the idea here is that there are resources available and the person receiving the services is controlling the who, what, where, when of those resources. For very flexible self-direction programs, we see some primary hallmarks. That a consumer manages a flexible budget. I'll talk a little bit more about what that means in a bit. That the consumer determines the mix of goods, but also services that meet his or her needs. And that the consumer directly hires, trains, supervises, and discharges the workers who provide service to the consumer. Next slide, please. So, as I had said before, self-direction or consumer direction programs, we have the consumer or someone close to them, this is often called a representative, who is at the center of the program overseeing and managing how their services are delivered and who provides them. So they're setting the tasks that a worker might do. They're, in many cases, specifying the salary and benefits, although not always. They're assigning a flexible work hour and schedule they're assigning the work hour and schedule. They are training and arranging the workers' training. They are making decisions about the needs and services, and they're recruiting, hiring, and managing their workers. Next slide, please. So, some key things to know about self-direction is that a self-direction program must have either employer authority or budget authority to be considered self-directed. Well, what the heck are employer and budget authority? Employer authority means that the person who's receiving the services, the consumer, or someone close to the consumer, their representative, can fully control who they hire, fire, and supervise. Now, I say fully. We're going to get into qualifications that might exist in a program such that they couldn't hire just anyone, but they could hire anyone they want who meets the qualifications. Budget authority means that a consumer has control over how the resources that have been allocated to them are used. As I said before, a self-direction program must have either employer authority or budget authority, but it can also have both. Right.
Come on.
Folks, if you could mute your phones, that'd be great. We're getting some feedback from our phone. Thank you very much. So employer authority means that a consumer can hire workers of his or her choice, and that the consumer will train, manage, schedule, and dismiss the workers. So it's deciding who I want to hire, then I hire them, and I tell them what to do. I set the schedule. If it's not working out, I say it's not working out, I got to let you go and hire somebody else. Often self-direction, although not always, consumers will choose to hire family members or friends. There are some self-directed programs that will prohibit the hire of family members, or they'll prohibit the hire of certain kinds of family members. So, for example, in the Massachusetts State Plan Personal Care Program, a consumer can't hire their spouse, but other family members are allowed. Potential workers may have to meet minimum qualifications set by the consumer's program. So minimum qualifications could include a background check, could include CPR training. There could be other qualifications also, but the general idea in a self-directed program is that the qualifications are set at a level that in general a consumer could choose whom they want to hire, and they would be able to meet the qualifications. Next slide, please. Budget authority is saying that there are resources available that have been allocated to a consumer, usually based on need, of course, and that within those resources, the consumer has pretty major say over how the resources are allocated. Now, that can take a bunch of different forms, but let me give a basic idea. Let's imagine a consumer is authorized, say, $3,000 for each month for their community-based services. Within that $3,000, the consumer will work with a case manager, a counselor, a support broker, again, this goes by lots of different names, to determine what mix of services and supports to purchase to meet the need. Now, of course, these services and supports are going to need to be Medicaid allowable services and supports. It's unlikely they're going to be able to pick something that they wouldn't be able to pick something that wouldn't be paid for by Medicaid to be able to meet their services and supports. They might decide to include some personal care services. They might decide to purchase some respite for a primary caregiver. In some cases, and we see this in the cash and counseling programs, as you've heard of that, and other programs like cash and counseling, a consumer could also choose to purchase some goods, not services, not labor. They could choose to purchase some things to help them, or maybe even a home modification. And when a consumer has budget authority, in general, they can also decide the rate of pay to pay their workers. Next slide, please. In self-directed programs, CMS is going to require that a self-directed program have two primary support services: counseling, which may go by many other names, and financial management services. Again, these could go by many other names. The support services are included to be provided so that program participants or consumers can remain in control of their services and supports, but that they have support to do that. Sometimes having all of this all of this control comes with a lot of responsibility, which of course the consumers take on, but with some support, specifically around counseling and financial management services. So without the counseling and financial management services support, we think self-direction could become overwhelming. Next slide, please. For the purpose of counseling, again, it's going to have so many names: support brokerage, skills training, options counseling. Generally, it's a function of helping the self-directed person, the person who's receiving the services, manage their budget or their authorization and decide what services to use, who to hire, how to, where to recruit people. If the individual is employing workers, then they might also be getting skills training around being an employer. What does it mean to be an employer? What are you responsible for as an employer, etc. Next slide, please. What's the purpose of financial management services? That's the other primary support in self-directed services. SMS providers are going to perform administrative responsibilities. So when you have someone hiring their own staff or hiring people that they've selected, oftentimes, and we'll get into this, they're going to be considered a common law employer. The IRS is going to consider them a common law employer, and as such, they must pay appropriately. They must pay wages appropriately. They must withhold taxes. They must deposit those taxes. The Department of Labor is going to expect them to pay in accordance with wage and hour rules. State tax agencies and state labor departments are going to expect the same for the state rules. And so SMS providers are often in place to support administrative responsibilities like handling the payroll, making sure the employment and insurance regulation compliance is maintained, making sure that anything that's paid for is in accordance with the consumer's budget or authorization. So consumers receive budgets that that they are able to figure out what sorts of services they want to receive, but they don't actually get the money directly in their hands. Instead, they will submit timesheets and invoices to this FMS provider who will make sure that whatever services were provided that they're requesting payment for match what's in their authorization or match what's in their budget. The financial management services provider will also have other controls in place to detect and prevent fraud and abuse. Next slide, please. So an SMS provider will generally support the consumer through an administrative process of being an employer. If it's the kind of program where the consumer is going to be set up as a common law employer, they'll support the consumer to make sure their workers are being hired legally. They'll conduct criminal background checks on workers if that's something the program rules require, ensure that workers and other providers are paid in accordance and compliance with rules and regulations, and they'll make payments in accordance with the spending plans, the budgets, the authorizations, and the program rules. Next slide, please. So, FMS can get complex. One of the hardest parts of this is that it goes by so many different names. So, financial management services is the general term given to the function of doing this administrative support around a self-directed program, handling the payroll on a self-directed program. So, financial management services, that's the general term for that function. Within that function, there are models of financial management services. So depending on how a program is designed, they might have really one of two models of financial management services. Are there others? Yeah, but they're not really used, so let's focus on two. Those two models are fiscal employer agent and agency with choice. So if you've been bouncing around in self-direction or home care for some time, you might say, well, wait a minute, what about fiscal intermediary? Why isn't she talking about fiscal intermediary? So fiscal intermediary, or FI, is an old term used to describe FMS, but these days it's an incorrect term. It also can be really misleading because the term fiscal intermediary, or FI, doesn't really tell you anything about what model of FMS is in place. And the model of FMS is really important for understanding who might actually be an employer here, what might some of the parties involved in the self-directed program, what might their employment relationship with the workers be. So I encourage folks not to use the term fiscal intermediary. Now, do some programs still use the term fiscal intermediary and FI? Yep, they do. But even if the program uses that, you could probably ask the program, all right, well, what model of fiscal intermediary is your fiscal intermediary? Fiscal employer agent or agency with choice? And knowing the answer to that, whether or not it's a fiscal employer agent or agency with choice, will give you a lot more information about how the employment relationship is likely structured. So, again, the term FMS is another one. That's the general term for the function. Just knowing, oh, there's an FMS provider doesn't really tell you too much more about what the likely employment relationships are. Just lets you know that, oh, there's a financial function here. Useful, but not complete. Next slide, please. All right, so let's talk about fiscal employer agent. Fiscal employer agent is far and away the most common model of FMS in self-direction. I'm forgetting the latest numbers, but I think it's something like 80% of self-direction programs use fiscal employer agent. The other 20% using agency with choice. So in a fiscal employer agent model of financial management services, the consumer or the consumer's representative, so a representative can be a family member, a guardian, can be someone the consumer has selected that isn't legally appointed or a family member, but with whom they're close and who wants to be very involved in the program. Usually it's the consumer, though. The consumer is the common law employer of home-based workers. We're going to talk in a bit about what common law employer means, for those of you that aren't familiar with that term, of workers who are employees. The consumer themselves is going to hire, fire, train, and manage workers. The fiscal employer agent is going to support the consumer to complete and file appropriate tax forms to become an employer. So it's actually going to be the consumer or the representative's name on paperwork to become an employer. The IRS will know of the consumer or the representative as an employer. The state tax agency, the state unemployment department, will have the consumer or representative listed as an employer. The fiscal employer agent is kind of a payroll company on steroids. They're much more than a payroll company, and they actually have liability with the consumer for the taxes in the eyes of the IRS. So they're more than a payroll company, and they're less than an employer. It is tricky. So the fiscal employer agent usually will manage applicable workers' compensation too, and help make sure that the consumer has workers' compensation in place. They're going to withhold deposits, file all the taxes. So they're sort of a supercharged payroll company who's also having some responsibilities from the state to make sure that the invoices and timesheets that are paid in accordance with budgets. In some programs, the consumer will hire workers and also work with non-employee providers, such as home care agencies, other vendors, independent contractors. Of course, the consumer won't be the employer of agencies, vendors, or independent contractors, but usually when those entities are paid because they're providing some kind of service or good to the individual, they will be paid by the FEA. Next slide, please. I gotta speed it up. We only have 8 minutes. All right, agency with choice. Agency with choice is interesting. Agency with choice in agency and consumer have a co-employment or joint employment relationship with the workers. Usually the agency is considered the primary employer. The consumer is considered the managing employer. The agency usually has the final say on who a consumer hires, but a consumer might identify someone they want to hire, refer them to the agency says yay or nay, hire them if they think it's a good idea, and then that worker provides services to the consumer. So with agency with choice, in general, the consumer is not a common law employer. The agency is. The consumer has usually a lot of control over the scheduling, a lot of control over who they hire, but the agency usually has the final say. Next slide, please. Okay, so within these two primary models of financial management services, fiscal employer agent, agency with choice, there can be variability about who the employer is for what purposes. I wish I could tell you it's crystal clear. If a state tells you there's fiscal employer agent, then the consumer is the common law employer, and there are no other joint employers. Or if agency with choice is the model, then you know there's a joint employer. I wish that I could tell you it was that crystal clear. Unfortunately, it's not, because different programs implement things differently. But I can tell you some things. So as you all probably know, different federal and state agencies view employment differently and use different tests of employment. Two primary tests of employment are the common law test and the economic realities test. Next slide, please. So common law employment. Common law employer common law employment generally recognizes there's only one employer, not many. And the common law employer in general is the entity that has the right to control and redirect the person who's providing the services. Common law test is used by the IRS, usually used in workers' compensation, usually used in state tax agencies. So the common law test does not recognize joint employment in general and only recognizes that there's one common law employer for any employment relationship. Next slide, please. Then we've got the economic realities test. This is what is used under the Fair Labor Standards Act. Sometimes it's called the FLSA test. And this test recognizes that there could be one or many employers simultaneously of a single employee. So this test can be more complex.
And so depending on how any single entity relates to an employee for actions related to the employment relationship, that entity may be an employer, as could another entity. So things like setting the rate of pay, hiring, firing workers, controlling hours and scheduling, setting provider qualifications, depending on who's doing those things, amongst other things, one or many parties could be an employer. If that is used by the Fair Labor Standards Act, if the home care rule comes back, people in self-direction will be thinking a lot about the economic realities test. Next slide, please. Okay, so one thing I can tell you is that in fiscal employer agent, that model where the consumer has more control, in general, the consumer is going to be a common law employer. In general, the fiscal employer agent will not be an economic realities test employer. In general, the consumer will be an economic realities test employer. And that's about where the generalities end. After that, depending on who interacts with the employee in the employment relationship, in what way, we could have other economic realities test employers. In general, an agency with choice, the agency is the common law employer, and the consumer is an economic realities test employer, as is the agency. And then, just like fiscal employer agent, depending on what happens after that, we could have no or more other Fair Labor Standards Act economic realities test employers. So, employer of record, you might hear people say employer of record. That is generally a misleading term that sounds like it is really important and means something, and doesn't really. Employer of record applies in staffing and professional employer organization contexts. It really doesn't apply in home health care, self-direction, or other general employer situations. It's not a term that the Internal Revenue Service really recognizes for those. It's not one that the Department of Labor really recognizes for those. It's misleading in self-direction because there are multiple tests of employer, like we talked about, common law test, economic realities test. The employer who is recorded as the employer does not matter a whole lot for a court or government agency who would deem an employer for different purposes. So who's recorded, it's a factor, but it's a not terribly important factor for who an employer is. Determining who the employer is based on the facts and circumstances of the parties' involvement in the employment relationship. Next slide, please. So, a couple of things to consider. The common law test and economic realities tests are different and don't always return the same result. Knowing the model of financial management services isn't enough to know for sure who is a likely employer for what purposes. But, as I said before, if it's fiscal employer agent, the consumer or representative is likely the common law employer. There could be other FLSA employers or not, depending on the program. If it's agency with choice, the agency is the likely common law employer. Next slide, please. And the agency is a likely economic realities test co-employer with the consumer. So, in summary, I'll speed it up here. In self-direction, consumer has control over who to hire or how to use resources allocated to them, or both. The model of financial management services, or FMS, helps to determine who some employers are likely to be, but the model alone will not dictate that. The facts on what parties do what related to the employment is what really matters. The term fiscal intermediary alone is meaningless for knowing who is a likely employer of workers. And understand that employer of record is not terribly meaningful. It's kind of a misleading term, and I would try not to use it if I were you. Next slide, please. All right. Great. So I think we have a little bit of time for questions.
Great. Thank you so much, Mollie. I just want to, it actually is 9:29, so first of all, I just want to thank Alison, Barkoff, and Mollie Murphy so much for sharing their expertise with us. Thanks to all of you who stuck with us on this call, because this was really a doozy in terms of technology not really working in our favor, so we apologize for that. Because the technology was such a problem on this call, we are going to have a partial recording of this training, but we will not have a recording of the part that happened after we switched phone numbers. So Alison Barkoff has already generously offered to redo the training at another point so that folks who wanted to attend but could not are able to attend, since the recording may not give them everything they need.
we'll be checking in to see if Mollie is able to do as well. But we just wanted to really thank the presenters and to thank all of you. There were a couple of questions. I just wanted to let the folks know who had questions that there's a set of questions that are Ohio specific that I'm passing directly on to Alison Barkoff so that she can give you a direct answer. I'm going to ask the one question that was a more general question that came in, which was, and everyone else just feel free to take off and leave the call. Thank you all for your attendance and patience. Mollie or Alison, final question before we end the webinar. This is from California. The question is, what was the highest, middle, and lowest population that uses HCBS?
Okay, I think you were referring to by disability population, and I can, if you forward me the person's email, I can give you the statistics, but the highest HCBS institutional to community spending is for population of people with intellectual and developmental disabilities. It goes down a little bit for people with physical disabilities and seniors, so that's more the nursing home population, and for people with psychiatric disabilities, it's a much higher institutional spending rate compared to community services, and in part it's because a lot of the authorities that I told you about that people with psychiatric disabilities cannot access. But if you forward me the email, I can send you the most recent statistics by disability group.
Great. Thanks to both of you so much. We will be sending out a link to another round of this training for your colleagues who are not able to attend this one because of the technical problems and the issues with recording. So you'll be getting that email. It's the same training, but it will be recorded and hopefully not sound like UFOs were descending upon us halfway through like happened this time. Thanks to all of you again, and thanks for all your work. Have a good day. This concludes this webinar.